Okay, this will cover the basics of glomerular syndromes. So, nephritic syndrome versus nephrotic syndrome. These are very frequent questions we get on the nephrology service, and we're going to give you the basics right here. So first I want to show you my cartoon of a normal healthy glomerulus. And so this represents 3 capillary loops in the glomerulus. And so the first layer is a healthy endothelial layer, and you can see it's fenestrated, so there's holes or windows in this layer. Next comes this pink line, which represents the glomerular basement membrane, and then on top of that are the podocytes or epithelial cells. And so, as you can see, they have these foot processes, these little tiny interdigitations, and in between those are the filtration slits. And the structure, as well as the filtration slits, form the glomerular filtration barrier. Sort of the glue holding everything together is the mesangial area, which is represented by these cells in the middle. So this is supposed to represent sort of how a healthy glomerulus, maybe a couple of capillary loops together, look. Okay, so now I've taken that cartoon and I've added glomerular nephritis. And so essentially what this means is that there's inflammation at the level of the glomerulus. And so in each capillary loop, I've sort of just drawn different main mechanisms of glomerular nephritis. So let's look at this capillary loop. You can see that there are inflammatory cells that have shown up. And so why are they here? Well, there's antibodies binding, and then there's complement. And so, of course, that will draw in inflammatory cells. And so when the inflammatory cells show up, they release their enzymes and recruit more inflammatory cells, and it just destroys the whole structure here. And you can see that the healthy podocytes, were blue, and so now they're pink, which kind of means they're sort of not feeling well. They're kind of sick, and we used to have really nice foot processes, and we've sort of lost that as this whole structure is injured and being damaged. And so this sort of capillary loop represents, immune globulin and complement-mediated glomerular nephritis. In this capillary loop, we don't see any of those things, but we do see inflammatory cells. And so like a pauci-immune glomerular nephritis, like the ANCA-associated vasculitis diseases, could be represented by this capillary loop. And then in this capillary loop, this represents a fibrin clot. So some diseases cause a thrombotic microangiopathy, like TTP or HUS, or the atypical HUS. So this can lead to inflammation at the level of the glomerulus as well. And so you can see in all these situations, the podocytes get damaged, they lose their foot processes, and if the inflammation is severe enough, it can poke holes through the glomerular basement membrane and cause a lot of destruction here. So this is kind of what is going on in my head when we think about glomerular nephritis, maybe one of these 3 mechanisms. Okay, so here's a cartoon of nephrotic disease, and so the way I think about this is that the podocytes are primarily affected, and you can see here that they're this sort of sickly pink color, where here's the sort of healthy blue color, and the healthy one has these little nice foot processes, and they have a intact glomerular filtration barrier with filtration slits. And you can see here that these podocytes that are sick, they've lost that, and so we call that foot process effacement. And so essentially the podocytes are injured, and eventually they lose their structure, and when they get sick, they sort of detach and they fall off and die. And then essentially what is happening, you're losing that really nice filtration barrier, and it leads to heavy proteinuria. And so essentially this is kind of what I think about is happening with the different nephrotic diseases. And these processes could be driven by immune globulins, so there could be sort of inflammatory-like process, but what you see here is an absence of heavy inflammatory infiltrate like we saw in the nephritic picture before. So you don't see here a lot of neutrophils or inflammatory cells activating everything. It's sort of just like the podocytes get sick and die and fall off, and there's a lot of different reasons for that you'll learn about later. Okay, so let's zoom in to the filtration barrier and talk about proteinuria. So remember, under the normal situation, these are podocyte foot processes with the slit diaphragm in between, and so normally small units and small molecules will be freely filtered. Low molecular weight proteins like beta-2 microglobulin and free light chains will be filtered, and so when they're filtered, they pass through tubules, and a lot of this is reclaimed in the proximal tubules, but obviously some of it is excreted. So what's happening with albumin in the setting of foot process effacement? So remember, normally albumin, because of its size as well as charge, it's going to be restricted. Okay, it's not going to be freely filtered. Maybe a little bit gets filtered, of course, but most of it is not going to get filtered. However, in the setting of foot process effacement, like we see with diseases that cause a nephrotic syndrome, now this albumin passes right through the glomerular basement membrane. And so when we lose this nice slit diaphragm with foot processes, now albumin can be freely filtered. And so albumin will end up in the tubular lumens. And so not all of it can be reclaimed by proximal tubules because the tubules aren't used to that much albumin. And then it gets spilled into the urine. And remember that there is some protein that is lost in the urine, like uromodulin. It's produced by the thick ascending limb. But when we say glomerular proteinuria, what we're really talking about is albumin, because this is the sort of the pathologic proteinuria. This means that there's a problem at the slit diaphragm. We've lost podocytes, they're sick, and at the level of the glomerulus, we're filtering albumin, which is something we shouldn't be doing. And so this is something we pay a lot of attention to when we're assessing kidney disease. Okay, so it is helpful to know these terms because you're going to hear these thrown around next year and in the future, and I want you to know what you're hearing and what it means. So the normal amount of albumin excreted per day is less than 30 milligrams per day. So that can be normal, but above that range, it's abnormal. And so here's how we break it down. If it's between 30 and 300, we call that moderately increased albuminuria. And so we used to call that microalbuminuria, but we're going to get rid of that term because it was confusing. Some people thought it actually was a separate protein called microalbumin. And greater than 300 milligrams per day of albumin excretion, we call it severely increased. Again, we're getting rid of this term because it was confusing. We sometimes use the word subnephrotic, and above that range is nephrotic, and we use the cutoff maybe around 3.5 grams of total protein per day. So less than 3.5 grams of protein per day. If it's, say, like 2 grams of protein per day, we call that subnephrotic proteinuria. But if it's above 3.5 grams of protein per day, we call it nephrotic range proteinuria. Now, the nephrotic syndrome is a collection of these things, okay? So not only do you have the nephrotic range proteinuria, but you also have hypoalbuminemia, okay? So the serum albumin concentration is less than 2.5 grams per deciliter. And there's also peripheral edema. So you have to have all three of these things to meet criteria for nephrotic syndrome. There's also hyperlipidemia and lipiduria, which is, it's not required for the diagnosis, but it is typically seen with nephrotic syndrome. People develop hyperlipidemia because actually the low albumin in the plasma actually stimulates lipoprotein synthesis at the level of the liver. And then also when you lose glomerular basement membrane, you start spilling a lot of those lipoproteins in the urine. And so that's why you develop hyperlipidemia and lipiduria. It's definitely important to know the nephrotic syndrome. Okay, now for the most important part of the slide, understanding nephritic syndrome versus nephrotic syndrome and how we interpret the urine. So you may hear us use the term nephritic urine sediment versus a nephrotic urine. And so this is essentially what I want you to take away, because you are going to be tested on this on your exams, but also in real life. And so the way we make this distinction is that we perform urinalysis. You can do tests on the urine itself, and we take a sample of the urine, we spin it down in a centrifuge, we resuspend the pellet into a very small volume of that urine, and then we look at it under a microscope. And how we interpret that is important, and that's how we distinguish between nephritic and nephrotic. Let's do it. Okay, so first, for a nephritic urine sediment, for a nephritic syndrome, the urinalysis can show white blood cells, because think about it, there's a lot of inflammation here, and those white blood cells can leak out and end up in the urine, so you can see white blood cells. Also, we do see proteinuria with most nephritic syndromes, either a little bit or a whole lot. It can run the whole gamut. A patient can have nephritis that can have a nephritic syndrome, also with nephrotic range proteinuria. And I hope that's not too confusing, but you can have a lot of proteinuria based on the degree of glomerular damage, okay? But the difference is that there's a lot of white blood cells, but also red blood cells, because think about it, these capillary loops have red blood cells flowing through them, and if there's enough glomerular damage, now those red blood cells can leak out and come out into the Bowman space and be filtered. And when that happens, we can actually see red blood cell casts. And so this is sort of a schematic of a red blood cell cast. And so if we're filtering red blood cells, they can actually get caught up into essentially a hyaline cast made up of that TAM horsefall protein or uromodulin. And so if we're looking at a urine sediment under a microscope and we see sort of a hyaline cast that contains red blood cells, well, that can only come from red blood cells that came out of the glomerulus and got stuck into the tubular lumen and then eventually got flushed out into the urine. And so this is incredibly specific for glomerular nephritis. And then we also look for red blood cells themselves. And, just seeing red blood cells by themselves doesn't mean there's a nephritic syndrome. So we pay close attention to the size and how the red blood cells look. If they look isomorphic, like they look healthy and normal, or if they look dysmorphic, which means they're misshapen and injured, that would point towards glomerular nephritis. And certainly, if we see red blood cells plus heavy proteinuria, we're probably leaning towards nephritic syndrome, a nephritis. Okay, now let's talk about nephrotic syndromes, or what nephrotic urine would look like. And so remember here, the podocytes they're sick, they're ill, they're losing their nice ultrastructure, and foot processes are now effaced, and the podocytes are going to fall off, detach, and die. And essentially we're losing that really nice filtration barrier, and we're going to spill lots of albumin into the urine. So the urinalysis, you won't see a lot of white blood cells, okay? And you are going to see heavy proteinuria. So on the urine dipstick, it may stain 3+ positive for protein. And the next step would be measuring the urine. So we do have a couple of tests. You can do a protein to creatinine ratio, like a spot urine sample, or you can give the patient a jug and they collect 24 hours of the urine, and then you measure and quantify how much protein that is. And remember, if it's more than 3.5 grams of proteinuria per day, we're getting into the nephrotic range proteinuria. And remember, most of this protein is albumin, because that's the thing that's now all of a sudden leaking across more than it should. Okay, really there should not be a lot of hematuria. Some of the nephrotic diseases can have a few red blood cells, but for the purposes of your exams, there's really not going to be much hematuria at all. And you can also see lipiduria and something called oval fat bodies. So oval fat bodies are sort of degenerating tubular epithelial cells that have sort of absorbed a lot of filtered lipid. Remember, we're not supposed to be filtering all this lipid, but the patients are hyperlipidemic due to overproduction of lipoproteins, and now they're filtering all these lipoproteins, and these degenerating tubular epithelial cells have taken up a lot of this lipid. And when we're looking under the microscope, under polarized light, we can see these things called oval fat bodies. And under polarized light, it sort of has this, quote, Maltese cross pattern, and I've sort of drawn it like here. So this would be highly suggestive of nephrotic syndrome. So typical nephrotic syndrome, no hematuria, maybe a few red cells, but not really. Not a lot of pyuria, no white blood cells, but heavy proteinuria. When you actually quantify it, it's extraordinarily high, and possible lipiduria. And so if you can make the distinction between a nephrotic sediment and a nephritic sediment, I think you'd be well on your way to understanding these processes.